the clinics during the night time. We've been doing these integrated sessions. Hello everyone, I'm Dr. Rohan Khandelwal.
Hi everyone, I'm Dr. Ilajan Khandelwal.
And today we bring to you a surgery and pathology integrated session where two topics where both surgery and pathology are very important, not only from the clinical point, from the exam point. You know that integrated medicine is the need of the hour, and those are the kind of questions which will be asked at exams. So this is just an endeavor to bring our dining room conversations to all of you. We've been doing these integrated sessions ever since our post-graduation days, where we used to discuss cases which we saw in the clinics during the night time, right? So this is just an effort to bring that discussion to you guys so that you can retain things for a longer period of time. Now, without wasting much time, let's start with the first question. We have a 36-year-old lady who is a Hodgkin's lymphoma survivor. And as usual, I'll be highlighting the keywords because I've told you that to solve these long stem questions, the idea is to identify these keywords. So she's a Hodgkin's lymphoma survivor who received radiation to the neck at 18 years of age. She notices a midline swelling in her neck, and on ultrasound, there is a unifocal 2 into 2 centimeter taller than wider lesion. Now, if you remember, taller than wider lesions, both in thyroid and in breast, taller than wider lesions signify that it's most likely a malignant tumor, right? A malignant lesion. Wider than taller means benign. So it is noticed in the right lobe of the thyroid without any lymph node enlargement. Ultrasound guided FNAC reveals it to be a papillary carcinoma thyroid, right? Now, you all know that FNAC is the investigation of choice for thyroid cancers, except for follicular, where it cannot differentiate between follicular adenomas and carcinomas. So now they're asking you the surgical management of this patient. If you remember, I have already covered that differentiated thyroid cancers, you know, DTC, you have papillary, you have follicular. These are the two most common types of differentiated thyroid cancers. In differentiated thyroid cancers, if it's a 1 to 4 centimeter lesion and it is a unifocal lesion, no extrathyroidal extension, then we can do hemithyroidectomy. But there are certain exceptions, and that is what I want to highlight, that the latest edition of Sevistan and the American Association guidelines say that although hemithyroidectomy is acceptable alternative to total thyroidectomy in low-risk differentiated thyroid cancers, which are unilateral that although hemithyroidectomy is acceptable alternative to total, that the latest edition of Sevistan and the American Association guidelines say that although thyroidectomy is acceptable alternative to total thyroidectomy in low risk differentiated thyroid cancers, which are unilateral between 1 to 4 centimeters without extrathyroidal extension. But what are the exceptions? The exceptions are radiation-induced differentiated thyroid cancers, familial non-medullary thyroid cancers, multifocal bilateral differentiated thyroid cancers, and extrathyroidal extension. So you need to remember these exceptions for your exam. And this question was based on one of those exceptions, which is radiation-induced problem. So that is why in this case, we will carry out a total thyroidectomy. Now, some of you might argue that why total thyroidectomy? Why not a central leg dissection as well? If you remember, I've already told you prophylactic central leg dissection, prophylactic CND is only done in T3 and T4 lesions. It is only done in T3 and T4 lesions. This is not a T3, T4 lesion, so you don't need a central leg dissection in this case. Now, once we've done a surgery, you all know that there are two ways to prepare the patient for a whole body iodine scan. One is the traditional way where we wait for 4 to 6 weeks, but the other method, which is gaining a lot of popularity, and another thing which you should know, is the use of recombinant TSH. So by using recombinant TSH, we can boost up the TSH and the scan can be done earlier. If there is residual disease or metastasis, then we give radio iodine ablation. This has also been asked many times in the exam. It is iodine 131, which acts via beta rays and the half-life is 8 days. Those patients where there is no residual disease or metastasis, we can use thyroglobin as the tumor marker. And this is another point which me and Dr. Ella want to tell you, that you know that there is a condition where there are anti-thyroglobin antibodies. And what is that condition? Hashimoto's thyroiditis. So in patients where there are anti-thyroglobin antibodies, thyroglobin is not a reliable tumor marker. So before we start using thyroglobin as a tumor marker, we always do anti-thyroglobin antibodies, and then we start using this as a tumor marker. So this was the management. I told you certain updates regarding the management of differentiated thyroid cancers. And now I hand it to Dr. Ella, who's going to talk about the pathology of thyroid cancer, which is asked almost every year in each exam.
So the thyroidectomy, which was done by Dr. Rohan, it came to me, and when I started grossing the tumor looked something like this. When I opened the thyroid gland, normally in the thyroid gland we see a follicles filled with colloid. Here you are seeing these gray white areas which are there, and sometimes when we have a papillary cancer, we can see these small papillary projections, right? That is how we identify that this can be a papillary tumor, and there are no follicles which are filled with colloid, right? Microscopically, students, there are very important points related to papillary carcinoma of thyroid, and they are mostly asked in the exam. The images have been asked in the exam a large number of times. So when I see the slide, the first thing why we call it as a papillary cancer is we see a finger-like projection. What is a papilla? It is a finger-like projection. But remember, students, every finger-like projection is not a papilla. Here I'm seeing these finger-like projections correctly, but you can also notice that these finger-like projections have these cores. The core of this finger-like projection is made up of fibroblasts and blood vessel. That is why this is called as a fibrovascular core. So as a pathologist, it is very important for me to identify that why this is a papilla, because it has a fibrovascular core, right? So papillary cancer anywhere in the body, whether it is kidney or whether it is lung or thyroid, it will have a finger-like projection with a fibrovascular core. Now, the important thing to notice here is these cells which are there. Can you notice these nuclei? Are these non-nuclei? No. You can see they're clear nuclei. The chromatin is dispersed. That is why these are optically clear nuclei which have an opened up chromatin. They're totally clear. And these nuclei have been given a special name, orphan Annie I nuclei. This kind of image with a clinical history has been asked in the exam a large number of times and is a future question always, right? So these are orphan Annie I nuclei, optically clear nuclei. Why are they called as orphan Annie I? Because I always say a pathologist is very fond of observation and imagination, right? We're very dream people. So when I see these nuclei, it looks like a cartoon character, which was a little orphan Annie, in which the eye of the nuclei does not have any pupil, right? So it's totally clear, and you can compare the nuclei to this, right? Two other important characteristics to diagnose a papillary cancer on histopathology are nuclear pseudo-inclusions. Now, this is not a true inclusion. It's a pseudo-inclusion. Why? Because it is formed by the invagination of membrane, right? Another characteristic is because of this invagination of membrane, the nucleus molds. There is nuclear grooving, and this nuclear grooving, it looks like a coffee bean. The nuclei starts looking like a coffee beans, right? So this is called as a coffee bean nuclei. So nuclear pseudo-inclusions and coffee bean nuclei, there are also other characteristics. Here I'll tell you another flashcard in pathology, students, which is commonly asked in the exam. The tumors in which we see nuclear grooves or coffee bean nuclei. Please remember this list for all your exams: papillary cancer thyroid, Brenner's tumor, granulosa cell tumor, Langerhans cell histiocytosis, and chondroblastoma. Correct? Lastly, the cancer thyroid, Brenner's tumor, granulosa cell tumor, Langerhans cell histiocytosis, and chondroblastoma. Correct? Lastly, the fifth and also very important characteristic of papillary cancer is the presence of these bodies, which are called as Samoma bodies. Right? 4 or 5 years back, this was a very favorite question of the examiner. Some bodies are not seen in or are seen in. Right? So this is another flashcard in pathology in which all conditions you see Samoma bodies. So they are seen in papillary thyroid cancer, any papillary cancer like renal cell cancer also, serous histiocarcinoma of ovary, meningioma, prolactinoma, and mesothelioma. Right? So this image can also be asked in the exam. Along the clinico-pathologic history. These are the 5 important points of how I diagnose papillary cancer of thyroid and histopathology. Now, I would also like to talk about a variant of this cancer, which is the follicular variant. Why this variant is very important? Because, I see cells arranged in follicles. So I start thinking, no, this is not papillary cancer, this is follicular cancer. But to diagnose a papillary cancer, the most important characteristic is the nuclear features like grooving, pseudointusions, and orphan honey, right? So in the follicular variant, although I can see that the cells are arranged in follicles, but the nuclear features are those of papillary cancer, right? That's why this is very, very important to notice. Then, newer entity which has been added in the 10th edition of Robbins and Sebastian also is called as non-invasive follicular thyroid neoplasm with papillary-like features, right? Why? Why is it called as non-invasive? Because it does not have any capsular or vascular invasion, right? And why is it important for a pathologist to tell the surgeon about this entity? Because it's a very low-grade neoplasm with minimal risk of recurrence and an excellent prognosis. Right? So these are the important features about papillary cancer. Over to Dr. Rohan.
So on a lighter, as Dr. Ella was saying, that pathologists are quite dreamy people and they like to imagine a lot. We had a common friend who in his second year viva of this gross specimen of thyroid, instead of identifying it as thyroid, he very confidently kept on saying it as a testicular specimen. Right? And he was so confident that he even described it as a seminoma. And the examiner also quietly kept on listening to it till the end. It was only when he got his result and he later went to spoke to the professor did he get to know why he flunked the exam.
And he even told the parts of testis like the epididymis and all.
Right. So you should know the gross specimens and the microscopic findings of thyroid cancers. They've been asked quite frequently in the exam. Moving on to the next question, a 31-year-old male notices a swelling in the neck. He's also having episodes of sweating and diarrhea. So there's a swelling in the neck, there's sweating and diarrhea. Ultrasound guide FNAC reveals amyloid-rich material. Now, just by reading this much, you know which condition we're talking about, right? So the surgeon discusses the case with the patient and also tells him about RET gene mutation. This is the other hint regarding the condition. The patient's wife is pregnant and they are expecting their first child in 3 months' time. I want you to review the following statements and we will do it like a true and false kind of question. This was made more of a INICET type of a question, but we'll do it like a true and false question so that you can learn more things about it. Now, by the keywords, it is already clear that this patient is suffering from a medullary thyroid cancer because of amyloid-rich material, which is a characteristic feature, and red proto-oncogene, which is also seen in Men's syndrome. So pheochromocytoma and hyperparathyroidism should be ruled out in this patient. This is correct because you know that in Men's syndrome, and specifically MEN2 syndrome, where you can get medullary thyroid cancers and you can get features of hyperparathyroidism as well. Patients should undergo red proto oncogene assessment. Yes, that is correct, because it has been seen that those medullary thyroid cancers which have a red proto oncogene mutation are more aggressive, and also because this couple is expecting a child in 3 months' time, it also has a bearing on the child's further management and how do we monitor the child's problems and risk of future malignancy. Total thyroidectomy with central neck dissection should be done. This is also true. Now, you know that medullary thyroid cancers are aggressive, and I've already told you that we should stay one step ahead of the tumor, right? So in all medullary thyroid cancers, we are at least doing a total thyroidectomy and central neck dissection, which is level 6 neck dissection. But there are certain conditions where you will even do lateral neck dissection. That is level 1, 2, 3, 4, or 2, 3, 4 neck dissection will also be done. So what is that condition? That condition is if the basal serum calcitonin value is more than 200. So this is a false statement. If the calcitonin, calcitonin is also a tumor marker for this cancer. If the calcitonin value is more than 200, then we should do a bilateral lateral neck dissection as well. Also, if there are palpable lymph nodes in the lateral chain, then also you should do a lateral neck dissection. Finally, if the patient is detected with an exon 9-1 mutation on red proto oncogene, the child should undergo prophylactic thyroidectomy within 1 year of age. This is also true. I'll just elaborate on this point as well. So, MEN syndrome is multiple endocrine neoplasia syndrome. MEN1 syndrome is because of the menin gene on chromosome 11, and this is known as Wermer syndrome. Don't confuse this with Werner syndrome, which is adult progeroid syndrome. Okay? Now, in MEN1 syndrome, typically you have 3 Ps: pituitary, parathyroid, and pancreatic endocrine tumors. The most common pituitary adenoma is a prolactinoma. The most common presentation overall of MEN1 syndrome is hyperparathyroidism, which is more likely because of an adenoma than hyperplasia. And the most common functional pancreatic endocrine tumor in MEN1 is gastrinoma, right? Overall, the most common pancreatic endocrine tumor is insulinoma, but in MEN1, it is gastrinoma. Don't get confused between these two. These 2 points have been asked quite frequently in the exam. MEN2 syndrome is because of red proto oncogene mutation on chromosome 10, and you can have MPC only, that is exon 618 mutation. You will only get medullary thyroid cancers. MEN2A is Sippel syndrome, where medullary thyroid cancer is the most common. Parathyroid adenoma, pheochromocytomas, and megacolon or Hirschsprung's disease. This is exon 6. Three, 4 mutation. is the most common mutation which is seen in red proton gene. MEN2B is also known as MEN3 syndrome, and you have 5 M's here: medullary thyroid cancer, marfanoid features, mucosal neuromas, megacolon, and medullated corneal fibers. This is because of mutation of exon 918. Now, the latest edition of Bailey and the latest edition of Citizen both highlight this very important point that these exon mutations tell us how aggressive the disease is and how early can it develop in a child who has this mutation. Okay? So 918 has the highest risk. That is why if somebody has an exon 918 mutation, then prophylactic thyroidectomy, prophylactic total thyroidectomy should be done by 1 year of age. So in the question, the child who's about to be born, he would also need to be screened for RET. And if 918 mutation is there, then the child will need to undergo a prophylactic thyroidectomy by 1 year of age. Prophylactic thyroidectomy can be done up to 5 years of age. So that is the importance of knowing these exon mutations. So as I've already told you that the histopathology of thyroid cancer is extremely important. So Dr. Ella will now highlight the histopathology of medullary thyroid cancer, and she will summarize in a table all the other thyroid cancers for you as well.
So medullary cancer of thyroid on histopathology is very simple, students. We just see two things. We see spindle-shaped cells, along with, as Dr. Rohan said, this pinkish material, which is amyloid. You can see this pinkish eosinophilic acellular material. It is completely acellular, right? So this is amyloid, right? So these are the two things which we see in medullary cancer and histopathology. Now, if I ask you a question that what kind of amyloid is this? This is ACAL. Why? Because calcitonin is a tumor marker for medullary cancer of thyroid, and calcitonin is normally produced by the parafollicular cells. You all by now know that medullary cancer is the only type of cancer of thyroid which does not develop from follicular cells. It develops from parafollicular cells which secrete calcitonin, correct? So that's why it's a tumor marker for medullary cancer. That's why it's also given as a keyword in the MCQ exams. And a latest question which has been given in Robbins is that tumor marker for cancer of thyroid which does not develop. Now, if I ask you a question that what kind of amyloid is this? This is ACAL. Why? Because calcitonin is a tumor marker for medullary cancer of thyroid, and calcitonin is normally produced by the parafollicular cells. You all by now know that medullary cancer is the only type of cancer of thyroid which does not develop from follicular cells. It develops from parafollicular cells which secrete calcitonin, correct? So that's why it's a tumor marker for medullary cancer. That's why it's also given as a keyword in the MCQ exams. And a latest question which has been given in Robbins is that if the tumor is calcitonin negative, what will be the marker, right? So in those cases, the tumor marker which we now use, Dr. Rohan, is carcinoembryonic antigen. Right? And
so the latest edition of Citizen also says that those medullary thyroid cancers which are CEA positive, that is a sign of dedifferentiation, right? And they are more aggressive than the normal medullary thyroid cancers. Also, because I mentioned that sweating and diarrhea can occur, so these and they are more. Citizen also says that those.
So in those cases, the tumor marker which we now use, Dr. Rohan, is carcinoembryonic antigen.
Right? And so the latest edition of Citizen also says that those medullary thyroid cancers which are CEA positive, that is a sign of dedifferentiation, right? And they are more aggressive than the normal medullary thyroid cancer. Also, because I mentioned that is a sign of dedifferentiation, right? And they are more aggressive. Says that those medullary thyroid cancers which are CEA positive, that is a sign of dedifferentiation, right? And they are more aggressive than the normal medullary thyroid cancers. Also, because I mentioned that sweating and diarrhea can occur, so these medullary thyroid cancers can also be associated with secretion of histamine and serotonin, which can give rise to these features.
So they can also be a keyword in the MCQ exams, correct? So this is about the histopathology. Now, pathologists, whenever, so as a pathologist, whenever we see amyloid and we suspect amyloid on a kidney stain, which is a special stain under amyloid which we do Congo red under polarizing lens. And what does it produce? It produces the characteristic apple green birefringence. In this image, can you people appreciate this? It has a golden yellow sheen, right? Golden yellow, apple green, right? You know why is it called as apple green? Again, definition of a pathologist. This is called as apple green because have you all seen those golden apples which are available in Himachal, right? So the color of those apples matches this color. That's why this is called as apple green birefringence. And another very basic concept is that why do we see apple green birefringence on Congo red under polarizing lens? Why? Because of the cross beta pleated sheet structure of amyloid. It's not simple. It's not an alpha helical structure. It's a beta pleated sheet structure which produces this birefringence, right? Now, with this brief, I'll give you this gist of all the thyroid malignancies because they're frequently asked in the exams, right? You all know that the most common and the best prognosis is papillary, whereas the least common and the worst prognosis is that of anaplastic cancer, correct? A very important thing which is given in the history screen a clinical pathology question is radiation exposure or Hashimoto's thyroiditis. Whenever you have this history, think about papillary. Whereas this question was asked in NEET exam a few years back, that which type of thyroid malignancy arises in iodine deficient people or hypothyroidism? The answer in that case is follicular cancer. Correct? Now, I would also like to tell you a very important point about genetics, right? For papillary cancer, two genes are important. One is the BRAF gene, another is a RET PTC, right? Follicular, two genes are impacted, KRAS, which is a oncogene, and PI3K. Medullary, as Dr. Rohan has already told you, RET on chromosome number 10, or it can be associated with Menke syndrome, and anaplastic is very frequently associated with P53, right? That's the genetics of thyroid malignancies. This question was also asked in exam 3 years back, that which type of thyroid malignancy metastasizes by lymphatic route, and the answer to that question is papillary. Hematogenous route is mostly for follicular cancer, whereas medullary and anaplastic usually follow by either lymphatic or hematogenous route, right? When I talk about histopathology, we already know about papillary cancer and medullary cancer. Follicular, the only thing which I would like to tell you here is that cells are arranged in follicles, that's why it's called as a follicular cancer. But as Dr. Rohan told you that you cannot do FNAC to diagnose follicular cancer. Why? Because you have to differentiate it from a benign entity which is called as a follicular adenoma. So when a pathologist says that this is a follicular carcinoma, we extensively take a lot of sections of the thyroid gland. Why? Because we have to look for capsular or vascular invasion, right? We see that whether tumor cells are invading the capsule and the blood vessels. If it is present, we make a diagnosis of follicular carcinoma. Correct? So this is about a brief gist of the various thyroid malignancies which you have to remember, right?
So before we move on to the next question, a few things which I want to highlight. That BRAF is the most common gene mutated in papillary. This question has also been asked. And as Dr. Ella was saying, that in papillary, lymphatic metastasis is more common than hematogenous. It is not purely lymphatic. Yeah. There can be hematogenous mets as well. Similarly, in follicular, hematogenous mets are common, but there can be lymphatic mets as well. So don't get confused. There will only be lymphatic or hematogenous. It's just that papillary has lymphatic more than hematogenous. Follicular has hematogenous more than lymphatic. Okay. We move on to the next question, which is also a very important question for the exam.
So the next question is a 38-year-old business executive. She presents to the OPD with a screen-detected breast lump, right? Ultrasound guided with biopsy reveals it to be an invasive ductal cancer. IHC for ER, PR, and HER2 was subsequently ordered, and the slide is shown below, right? Patient is really concerned about her treatment. Which one of the following statement is not correct regarding her management? It's a simple question. In a way that you know that this is ductal cancer, what you need to know is how to identify or interpret these IHC slides, right? So before I move on to the various options, I will tell you that how do we diagnose these various ER, PR, HER2 markers, right? So one funda which I would like to tell you here is that whenever we do immunohistochemistry, if some cell is positive, it gives a brown color, right? So when in exam you see brown color on a slide and it is an IHC slide, that means that is positive. And when the cells are not taking any color, it is negative. Correct? That's a basic funda. Now, what can get stained in a cell? Either the nucleus or the cytoplasm or the membrane. These two are the basic fundas which you have to remember. Now, in this image, if you're a layman, this is ER, this is PR, and this is HER2 new, right? I can see that there's no brown color in ER, PR, HER2 new, right? Even if you don't know anything else, you see that there's no brown color. That means all these three markers are negative, right? With this basic funda, all these three markers are negative. That means this is a triple negative breast cancer, right? Now, I'll actually show you how to identify these markers. So in this image, this is estrogen receptor, this is progesterone. In the left side, I can see that the cells are not taking up any color, any brown color. So this is negative. On the right side, I can see these glands, which are the nucleus is beautifully stained brown. That means this is ER, PR positive. You all know that ER and PR are hormonal and steroid receptors. That's why they produce nuclear positivity. So what is stained here? The nucleus. Another image which is beautifully showing these nuclei stained positively, right? So a pathologist students very commonly does a scoring. When the surgeon sends me a slide, I have to inform the surgeon about the Aldrich score, right? That's the scoring which we do for estrogen and progesterone receptors, which is very important. Aldrich scoring, we see two things. One is proportion of cells which are affected, and another